Dr. Roberts, thanks for joining us.
My pleasure, Dr. Ablow, and please call me Jim.
And please call me Keith.
I will, Keith.
So enter Cavadex, and what was your initial experience with it that led you to this journey with Cavadex, with cyclodextrin?
Well, I started on patients with inoperable recurrent heart disease. They were stuck. Their stents had narrowed, their grafts had closed. They were on maximum medical therapy. There was nothing more to offer them. Well, why not try Cavadex? Why not? And they started getting better. There were patients who required repetitive therapies. We put them on Cavadex. Now I see them twice a year. We kind of shake hands, say, hi, how you doing? Oh, I'm doing fine on my Cavadex. So with that experience, the too far goners getting better, now I feel kind of quite comfortable recommending Cavadex to almost everybody if they have a significant narrowing and if there's a need to resolve the disease rapidly. Because I'm not going to hurt you, I can only help you.
Obviously, in order for you to have decided, okay, for the folks who are most at risk, we may as well try Cavadex, you had a theory. You had looked at the science and said, well, this might work. What was that like for you? Why might Cavadex work? What's the molecular rationale?
In animal models of atherosclerosis that translates to human atherosclerosis, it works. And the body does want to pull cholesterol out of the artery wall. If you have an early plaque and you remove the cause of this disease, you stop smoking, you lower your blood sugar, Mother Nature will resorb the plaque. Reverse cholesterol transport is a natural process, and Cavadex accelerates that. So it's stimulating Mother Nature's vascular repair program. That is totally appealing. With drugs, they're therapeutic poisons. They're inhibitors or blockers, and they can provide benefit, but we can harm you because we're interfering with one of Mother Nature's processes that is overly active. With Cavadex, we interfere with nothing. We stimulate Mother Nature's vascular repair profile. That is quite satisfying.
I know I'm getting into the weeds a little bit, but I wanna. So by Cavadex stimulating that process, what is happening molecularly that explains how Cavadex would facilitate that?
Cavadex looks like a traffic cone. You take starch and you digest it and break the sugar bonds to create a cyclic sugar structure called cyclodextrin. And it looks like a traffic cone. The outside is water soluble, so it can exist in the circulation. The cavity is fat soluble, and into this cavity you can fit a cholesterol molecule. So we can envision the vessel wall, the cell membranes, they're gelatinous, they're permeable, they're in motion, they're composed of fats and cholesterol and proteins. So Brownian motion exists, so a cholesterol molecule will pop out. Because it's fat soluble, it doesn't want to hang around the circulation, it can just pop back in. Unless it meets an HDL molecule, which will grasp it and take out the liver. That's why we want to have a high HDL. Cavadex will sequester a cholesterol molecule. It basically plucks it out of the vessel wall, hands it off to an HDL, then plucks more cholesterol out. So we have Cavadex in the circulation, molecule by molecule pulling cholesterol out of the cell membrane. Then lipid droplets, stored cholesterol in the cell, will be mobilized to replace the cell membrane. So molecule by molecule, we're taking cholesterol out of the cell membrane and out of the cell itself. We also remove diacylglycerols, which is a cholesterol-like molecule, fatty acids on a glycerol backbone. Those molecules will inhibit the generation of nitric oxide. Now, nitric oxide is our biochemical Teflon coating. It dilates our arteries. It promotes resistance against infiltration of the artery wall with white cells and platelets. We want to make a lot of nitric oxide, and Cavadex increases generation of nitric oxide. Now, advanced plaques, complicated plaques, contain foam cells. These are white blood cells that enter the artery wall and gobbled up oxidized lipids that look to the body like an infection. So in a sense, atherosclerosis is a maladaptive response to the immune system, what it perceives as infection of the artery wall with cholesterol that enters the artery wall and becomes oxidized. These are inflammatory cells. They're releasing free radicals and inflammatory mediators. They will convert adjacent normal cells, vascular smooth muscle cells, and endothelial cells to become foam cells. All of a sudden, this plaque is an inflammatory generator, and these inflammatory cells will drink in adjacent material. It's called pinocytosis, and they will incorporate the cavadex. So now we've got the cavadex in these cells that has ready access to lipid droplets. And there's crystalline cholesterol. Crystalline cholesterol is particularly malignant. It mediates plaque activation, and we are going to dissolve the crystalline cholesterol. We're going to get that out of there. In the process, as you dissolve crystalline cholesterol, you create a class of compounds called oxysterols. Mother Nature doesn't want to see those. So when we have oxysterols in the artery wall, we start creating pumps, cholesterol efflux pumps, that will grab the cholesterol and pump it out and hand it off to the HDL. So we have these inflamed plaques full of foam cells. We get cavadex in there. All of a sudden, they're pumping cholesterol out and turning off inflammation. The sicker the individual, the more you're going to get out of cavadex, because the more is going to get vacuum into the cells.
So here we have these cone-shaped molecules. They are absorbing, if you will, into their center,
yes,
a cholesterol molecule, one per cyclodextrin molecule or Cavadex molecule, handing it off to HDL. Take me back into my physiology class. Where do we go from there? Where does the HDL go from there with the cholesterol?
Right. So the HDL plays a role in this process of reverse cholesterol transport. It will grab cholesterol, egressing the vessel wall, take it back to the liver. The liver will take up that cholesterol, and if the liver needs cholesterol to make things, it'll use it. If not, it will excrete that into the GI tract. It goes out in the stools.
Got it. Now, here's something really interesting. Before you gave it to patients, you made yourself the patient, if I get it right.
Absolutely.
Tell me the story, because again, like, this is not something they teach at med school.
Right.
No one told me, use it on yourself first, Keith.
Right. I learned about the Zimmer paper, the research that showed that Cavadex works several years ago. I went online to find out more about it. There were no sources of Cavadex. I had no idea what it was. I thought it was a drug, so I forgot about it. Then a year later, a patient comes to see me and goes, hey, do you know about Cavadex? Oh, what's Cavadex? Oh, you got to look this up. So I go online and I see the Col-Rem website. Oh, that's that stuff. So I email them. I tried calling. It was late in the day. I email. I'm interested in this. On Monday morning, a package of powder was on the doorstep, and it was Cavadex. So I called them, and they go, yes, you can treat yourself. Just mix it up with normal saline. Now, by then, I'd read 25 papers, and we mixed it up, ran it through a filter. It's benign, and I had my IV. And, of course, I noticed nothing. I couldn't even tell I was getting it. No trouble at all. I don't want to be too graphic, though. The urine output was frothy.
Okay, no, it's not too graphic.
That's cholesterol coming out of my arteries into the urine.
Got it. Okay, and so your motivation for doing that, by the way, was simply because you're a human petri dish, or because you had a problem?
I should be the guinea pig. Okay. You know, before we have patients take it, you know, it's all brand new. Nobody knows anything about it. So I thought, you know, before I tell a patient to do it, just, you know, because I think it's a good idea, I should expose myself to it. And of course, it was no big deal. So I received 50 infusions, and I didn't have any trouble at all, because you can't hurt anybody with Cavadex.
And after the 50 infusions, and you wouldn't necessarily, because you didn't have pathology that you were aware of, but did you notice anything in the way of benefits?
I didn't do it correctly. I did it 3 days a week at first, and then we would get busy. We'd have vacations. So I did it hit or miss, basically so I could say I did 50 to make sure it was safe. But we did look at my carotid arteries.
Okay.
And over the years, I developed a little bit of plaque. It's common, but not normal. And after 50 infusions, I had a little bit less plaque. Now, I didn't have much plaque to begin with, so I didn't have a whole lot to gain, but I did get a little bit better. If I had a lot of plaque, and I did this correctly, I probably would have had a lot less plaque. But anyway, so we did it with me, basically not to prove that it would reverse my mild plaque, but to prove that you can't hurt anybody with this.
So on to the patients, and as you said, you start with the highest risk people. You're like, look, first do no harm.
Yes.
These folks are not doing well.
Yes.
Nothing's working. They've had what they can have. And now we introduce Cavadex. And so what was your experience in that regard with that cohort?
Remarkable benefit.
How so?
Remarkable benefit. Their chest pain improved, they were less short of breath. And I believe it's the nitric oxide generation. Many of these people have blocked arteries and natural bypasses called collaterals that are nitric oxide dependent. You take Cavadex, your arteries become nitric oxide factories. So collateral flow improved. Inflammation is attenuated. So we're making nitric oxide, promoting collaterals, turning off inflammation, you have fewer symptoms. So though we're helping with collateral flow, and I believe we're opening up arteries. If you have a 90% narrowing, and we convert it to an 80% narrowing, which I believe we're doing, blood flow will double. So these patients were having they had a huge upside potential, and they got better rapidly. And if we keep them on Cavadex, we're keeping them out of trouble for the most part.
That's not intuitive even to me. I'd have to refresh my calculus mind or something. But you just said if you go from a 90% blockage to an 80% blockage, your blood flow doubles.
Yes.
How does that work? Number-wise.
Yes.
Blood flow has to do with the square of the radius.
Okay.
So if you have a 70% narrowing, that is not really compromising blood flow. When it's an 85, 90, it is. It's sort of a threshold. Once you get to that point where you're obstructing blood flow, if you improve it just a little bit, all of a sudden you're not obstructing blood flow. So you don't have to resolve the plaque. All you have to do is begin to open it up while lowering inflammation, while generating nitric oxide, and you get a clinical benefit.
Fascinating. All right, so with that as a physiological backgrounder and rationale, you then give it to the highest risk patients. You see remarkable things happening.
Yes.
You have a theory behind that. And do you have data, whether it be imaging or calcium scores or anything else related to that group of people that would say, yes, and we have a little bit of data here that suggests, well, that's why you feel better.
Yes, we are collecting outcome data on our patients. Carotid ultrasounds, we look at endothelial function, we can measure that non-invasively. 2 patients demonstrated a reduction in their coronary calcium scores. One individual had a CT coronary angiogram, a non-invasive angiogram, before and after, got better. Stress tests are getting better. Now, these are not randomized double-blind studies. We would call these anecdotes. But when all your patients are demonstrating some benefit, then it's science for you. And we will be doing a study with 50 patients. We're going to do their coronary calcium score, 6 months of Cavadex, and we're going to repeat it. The calcium scores progress at 20% per year. On average, if you're at 50%, that augurs a good outcome. No one has ever demonstrated reversal. I think we're going to demonstrate reversal. If we reverse coronary calcification, that would suggest we're opening up the arteries. In the future, we will do studies with CT angiograms and non-invasively show that the arteries are actually dilating. So there's more testing we'd love to do to prove the point, but right now, with the testing we do in the office, we're seeing benefits that corroborate the patient's symptomatic improvement.
FDA, you're not afraid of FDA or the Board of Registration coming in and saying, that's it, doc, you're done?
Well, the FDA does not have jurisdiction over my medical practice. They can block importation of Cavadex, but they don't control me. Medical boards control me. And if I'm doing something dangerous or reckless, they would come and interview me. However, I have so much science to back myself up that I would be immune to any sort of regulatory interaction because everyone's getting better, and here I can prove it, and here's a stack of 50 scientific papers talking about how it works in animals. I am not worried about that.
This is not, by the way, to that point, this is not cyclodextrin's first rodeo, right? This has been used for an illness. You're repurposing cyclodextrin. You're not, from the start just saying, oh, well, there's this molecule, maybe it'll help with illness. It's been used for illness.
No, humans are taking it right now. We administer to you unloaded cyclodextrin to pluck a cholesterol molecule out. If we mix it with a drug, it enhances delivery of the drug. So in prescription agents today, it's the drug bound up with cyclodextrin. It's considered an inert ingredient, and the FDA approved this, and they call it GRAS, generally regarded as safe. Cyclodextrin is used in the Johnson & Johnson COVID vaccine. So it's not like humans aren't receiving it. Now, Niemann-Pick is an autosomal recessive disease state where you lack Niemann-Pick protein.
Kids, I mean, well, this is from birth, right?
Right, yeah. Right. You can't take cholesterol out of your cells. So your cells overfill with cholesterol, you die of liver failure or brain failure before you turn 10 years old. Well, if the problem is too much cholesterol in the cells and cyclodextrin will remove it, why don't we try this? So 10 to 15 years ago, doctors began to treat these kids with cyclodextrin. They gave it subcutaneously and intravenously, and that cleared the cholesterol from the liver, but not from the brain, because cyclodextrin will not cross the blood-brain barrier. So they would infuse the cyclodextrin into the spinal column, into the cerebral spinal fluid, so you could get a high level of cyclodextrin to the brain, and it worked. You delipidate their brain and liver, and they survived. Now, that one complication, that high dose of cyclodextrin to the brain compromises hearing.
If it gets into the CNS.
Yes, if you infuse it into the spinal fluid, all right, that's a fair trade-off. When we take cyclodextrin rectally or IV as I did, it will not enter the brain, so there's no hearing loss with cyclodextrin as we are utilizing it. But again, it's FDA approved as an orphan drug to treat kids with Niemann-Pick disease. So it's been around for a while.
So here you start with the folks who you might describe as having the least to lose. They are responding to nothing. They start responding to Cavadex. And then the journey takes you, I would think, to folks who aren't absolutely at the end of the road, but whose illness you could interrupt and or reverse. So what has that been like?
Okay, so which patients are going to benefit? At what stage we want to intervene? So our too far gones, that's easy. What about people with moderate disease that we think is going to become a problem in a couple years? We're recommending Cavadex. Maybe 2 to 3 months and then maintenance therapy while we work on risk factor reduction. Risk factor reduction removes the cause of the disease to slow down its progression. Cavadex removes the disease. It's kind of like soap to clean a dish. You know, the dish got dirty, you're going to clean it off. So we're lowering risk factors, we're taking out the plaque. It's an easy recommendation to make, the downside being the trouble taking it rectally and the expense, which is not huge, particularly compared to what open heart surgery would be. So people with severe disease, moderate disease, it makes sense. You know, if you have very early disease, you can take it, but it's really not necessary. You're not at a point where we have to melt away the plaque. If you're asymptomatic, you need to work on risk factor reduction. Hopefully you'll never get to the point where you need Cavadex, but we have it in our back pocket. Now, the only exception to that is some people have early disease and I cannot lower their cholesterol. They can't take any drugs. They have other problems that are refractory to treatment. Okay, I'm not going to do a good job with risk factor reduction. Your disease is probably going to get worse. So what do? We have you take Cavadex 1 month, 3 times a year. To kind of make up, we could, in this situation, use Cavadex to make up for the imperfections in our preventative program.
Well, yes, I get that, and but I would imagine if you're a human with a family history that is not reassuring, with a high cholesterol, and they say, we've imaged your coronary arteries, and yeah, you have some plaque already, would you say, well, you're asymptomatic, but let's...
You have nothing to lose. You have nothing to lose. You have nothing to lose here by doing
Why do
this.
you say that with such confidence?
Because we cannot harm you.
Why?
Because Cavadex does not interfere with bodily functions. All it does is pull cholesterol out of the artery wall where it's not supposed to be. That's all it does. All the benefits accrue from that simple step. So we cannot harm you with it. It is starch. Starch is not dangerous unless you eat way too much of it.
So I've had this discussion with a few other doctors or sometimes lay people, right. And they're like, well, but doesn't every cell need cholesterol? What if you deprive too many cells of cholesterol? There's an answer to that.
Right.
That's not happened.
Right. So we are not interfering with the ability of the liver to generate cholesterol. We're not poisoning the liver. So let's just say we gave you Cavadex for 10 years and pulled all the abnormal lipids out of your artery wall. I don't know if we could pull out physiologic levels or not, but let's just say we did. The liver can compensate by making more cholesterol. So I don't think we can cause a cholesterol deficiency situation with cyclodextrin.
So, you know, sometimes there are things clinically in my practice that have blown me back in my seat, and I remember them forever. You know, really amazing transformations in clients, patients. Do you have a few that you'd say, if you want to think about what cyclodextrin really might be able to do, here's a couple examples?
Well, the patients who are too far gone are getting better.
Okay.
We are showing that we're regressing plaque. People feel better. Of interest, mental clarity and mood is improving. It might be that if you have atherosclerosis in the vessels to your brain, that's leading to the release of inflammatory mediators. Inflammation compromises mood and memory. If we turn that off, your mood and memory might get better. Patients have commented on that.
Even though this isn't entering the CNS, when given rectally, reducing inflammation might have a benefit psychiatrically.
Yes, well, we're getting into the vasculature, and if those vessels are releasing inflammatory mediators, they will affect the brain. So anything that quiets down inflammation is going to be good for the brain. But patients said, my memory's better, my mood's better, I just like it. And doc, I don't really want to stop. I know you said I could go to maintenance, but I really like taking it, I want to keep taking it. I get that all the time.
Fascinating. And so now we run into a problem, which is that the government, the FDA, has said, well, you know, you're saying it helps people cardiovascularly. You can't say that. We're going to seize it and not let it into the country because it's coming from outside the country. What would you say to the FDA that might lead them to say, well, that's true, maybe we should reconsider?
Well, we hope that they will reconsider, but we can point out to them, A, they've approved cyclodextrin as a drug delivery vehicle. B, they've approved cyclodextrin to treat humans with Niemann-Pick. If FDA approves an agent to treat one disease, we're allowed to use it to treat any disease. In addition, if a drug is manufactured overseas and not here, you're allowed to bring it in. So there's a lot of arguments we have for the FDA to let us utilize cyclodextrin. I think it's a shame. It was, before anyone knew about it, it was a nutritional supplement. Now that it's working, it becomes a drug. You know, just because something works doesn't necessarily mean it's a drug, but the FDA, their job is to regulate drugs, so I guess everything looks to them like a drug. We hope that we can change this.
If you were speaking the language of the FDA, you would embark on animal trials, human trials, you'd have $1 billion, literally $500 million to $1 billion in your pocket, and you'd walk this through trials that would take 3 years, and maybe you'd get an indication for atherosclerosis in humans. Maybe.
Yes.
But how should it look in this case? Because this is a presumably non-patentable molecule. What should the path look like to widespread acceptance?
Well, there is a pathway to obtain FDA approval for nutritional agents that have been used before. It's still going to be time-consuming and expensive, but it's not millions and billions of dollars. But I think if we can educate the government and government regulators that this is safe, we're helping people. And by the way, guys, think of all the billions of government dollars that you're going to save. Let's say Medicare adopted this and allowed people to take Cavadex instead of open heart surgery. This would be great financially, great for humanity. And I think if enough people know about this, they're going to start talking about it, and they might want to pressure their elected representatives, say, hey, I don't want to die. Would you please tell the FDA to let me have my Cavadex? Isn't my life more important than the financial interest of big pharma and big medicine? I hope that that happens.
And you are not suggesting, just to be clear, you're not saying to people, stop your medicines, don't go to the interventional guys, just use Cavadex. That's not the point here.
No. I practice integrative medicine. There are no deep secrets of cardiology that I was denied. My patients do need procedures from time to time, but we minimize it. If I give you a drug, I ask what nutritional deficiencies are going to occur. I want to fill them in. So we use drugs and non-drug approaches, and we're not telling people to not undergo. If you come in with severe chest pain, you're red hot, that's too little too late for Cavadex. You need to go get a heart cath and a stent, and then we do everything else. Now, because Cavadex is working so well, there are some people who are refusing their doctor's recommendations to undergo procedures, and they're saying, I'm just going to take Cavadex. And they do that, and many come in to see me because they know I'm excited about it. And that was their call, not mine, but it's their body, it's their decision, and my job is to help them as best I can, and they all seem to be doing better. I think in theory, if we have the luxury of time, we can reverse the disease in everybody. Now, if you got a 99% narrowing and you're gobbling nitros, it's too late. But if we have the luxury of time, I think we can help you, particularly if we combine Cavadex with everything else I've been doing the last 39 years that would help.
Well, at a certain point, this gets personal, not professional, because if you can't get the Cavadex, let's say, God forbid, you would be presumably saying goodbye to patients that you wouldn't, because they might perish. You would not be saying goodbye to. You're convinced of this. You're sure of it.
I'm convinced of this. The patients are terrified. They were having trouble, they're getting better, and now our government cuts them off and they're having pain again. They can't believe it. If it's this good, why is the government inhibiting us? Because the government does not really understand what it's doing right here.
What do you tell those people?
I tell those people to be patient. I think the situation will change. They can write letters to the FDA. They can speak with their elected representatives. We do our best to find a way to supply them with Cavadex. The FDA is interdicting Cavadex, but not completely. So some of the shipments are getting through. So if your supply is interdicted, you may receive another supply later on that goes through. It almost depends upon the mood of the customs and FDA people that day. It seems to be that way. So I think that we will win this battle, because it's going to be pretty difficult for an elected representative to ignore a constituent says, gee, I don't want to die, I want to take my Cavadex, and then we educate the decision makers. I mean, they're going to want to take it. You know, they don't want to have open heart surgery if they could get better. So I think it's just going to take time to get in everybody's brains.
We both know the founder of the company that makes Cavadex, Calrem,
right.
Kyle Hodgetts.
Right.
So tell me his story, because you had 50 infusions of Cavadex, or cyclodextrin, Cavadex, but he predated you in that journey, and how so?
Right. Well, everything I've learned independently. I did not just learn it from Kyle, but I studied the science, he studied the science. We're saying the same things, because that's what the science says. He's just years ahead of me. He took that Zimmer paper, and he was having trouble. He had stents and recurrent disease.
He was going to die.
So he is a die. So he really needs to know this, and he's not getting the solution. So his doctors were not providing the solution. So he's a research-oriented person. He finds his own solution. This is quite remarkable. One guy helping himself is going to help the whole world.
That's an incredible story. Do we have something? Maybe we do. Maybe we have a reference point in the history of medicine for something that sounds the same or that echoes that kind of story. Is there?
I don't know. I mean, we stumble across good things, but I don't think we've ever had an individual find a solution and then tell us doctors. We're supposed to be the ones out in front telling the patients, well, here we've got Kyle getting better, talking, he got better, and if he got better, why should everyone else get better? So he founds the company, and he starts talking about it, and one by one, we doctors are hearing about it. We're talking to our patients, we're giving interviews. The ranks of Cavadex believers will grow.
You're a rare analytical thinker. right? That not everybody is, not even in medicine. But I'm going to ask you, the chances, when you run the numbers in your mind, that in retrospect, you'll look back and say, how could I have missed it? This actually is not good for people. What are the chances? What are the chances that you would look back and say, I guess I was wrong, it's not good for people?
Right, sure. Well, I think with my 2.5-year experience, I can say it's zero. You know, when we first started, you know, it looks good in animal models. We want to make sure it works. So I go first, and then my patients, nothing to lose, go second, and they're getting better. And now I've observed no side effects other than nuisance. Nor would we expect side effects based upon all the animal models and cell culture studies. Now, when we get involved in new treatments, every now and then we backtrack. Half the things we do in medicine, we stop doing after 10 years because it didn't work, there was hidden harm, or we have better methods. So we're always checking ourselves. So we keep outcome data. We pay attention to what's going on to guide us. Is it working as well as we think, as we predicted? And with Cavadex, it's working better than we predicted.
And for the scientists, doctors, researchers out there, we're past placebo effect. Like we're not seeing people who are excited to do it, so they're walking further and saying, I have no pain. That's not what's going on.
Oh, that's just not possible. And the placebo effect would not lower your coronary calcium score.
Presumably.
Or improve endothelial function.
Exactly.
So, you know, it's not a pleasant therapy to take. It's the mini enema. You know, so there wouldn't really be a placebo effect with a mini enema, I wouldn't think. So they're taking it because they know they need to get better. So I understand placebo effect. If I convince you that something's good, you're going to feel really good, and that's good for your physiology, but it's not going to reverse coronary calcification.
Which you're seeing.
Which we are seeing we doctors want objective data. Just because your chest pain goes away, that's subjective. We say we want hard data. Well, carotid ultrasound's getting better, endothelial function getting better, coronary calcium scores falling, that is hard data.
And you can't give me, because I'd like it if you could, I wouldn't like it, but I wish you would if you could, give me a bad story about somebody that you would say, yeah, I don't know, this is the outlier. I gave them Cavadex, 2 days later, they're like, my angina is 10 times worse. Never happened.
That has never happened. The worst thing that happens is you cannot tolerate it.
What does that mean?
Oh, the people with irritable bowel who have cramping and gas and bloating, they have trouble simply with physically putting this material into the rectum. 2 patients had diverticulitis. They got antibiotics, and then they went back on Cavadex. I think that was a fluke because they have a history of that. So I just don't think we can hurt anybody. It's the nuisance side effects that are the problem. Now, if we all took IV Cavadex, we'd have no trouble. But again, you'd want to get the IV daily. That would be prohibitively expensive. Now, Kyle did it because that was his only option.
Yeah.
I can do it because it's kind of fun during my lunch hour. But practically, to get an IV every day for 3 months would cost a fortune, and why would you want to do that? So we have not treated any patients with IV Cavadex, just me, because it would not be cost effective. And I think if you do IV Cavadex once a week, that's probably not going to do a whole lot of good as opposed to daily cap. So you want to get this process of reverse cholesterol transport rolling, and you want to support it each day, pulling more and more cholesterol out. So I think daily rectal therapy is far more effective than intermittent IV therapy. But we've had no disappointments.
So let's say bad things happen. The FDA, interdicts it all at the border. Nobody can get it, this Cavadex. And we're looking 3 years from now. What's been the toll in human life, do you think?
It would be a disaster.
Why?
Because my patients would die.
And yours, and presumably...
A lot of people would die of vascular disease. They'd undergo...
You don't have to.
They don't have...
You're convinced of it. They
Absolutely.
Don't have to.
So if you had a bypass surgery 10 years ago and your grafts fail, your second bypass surgery is far riskier than your first. I don't think you're going to have to do that with Cavadex. So if we deny people Cavadex, they're going to undergo high-risk, expensive procedures with lots of complications. This is a disaster. It should not happen.
So would it be fair to say to the government, look, let it through and take note of the epidemiology and the data. Start collecting the data. You'll convince yourselves. Put everybody on a program. Would that?
Yes, and I would love to be involved with that.
I can tell.
If we could have a format that we could work with the government and get them excited about it, perhaps do a clinical trial at maybe a military hospital.
Sure.
And we could make that, they'd save money, just do a military hospital. Why not do that? I think that's quite feasible.
Well, and again, money doesn't always rule the day, but in these days of Make America Healthy Again and the Department of Government Efficiency, how much might be saved if we...
Oh, billions. My understanding is that we spend on healthcare, really disease mitigation, $100,000 on every American pre-Medicare and $250,000 on Medicare. And most of that is at the end of life doing invasive procedures in the hospital. We could save huge amounts of money. If we don't have to be sick, we don't have to have procedures. I'm 69. I have not spent my first Medicare dollar. That would be pretty cool to live to 90 and not spend any Medicare dollars. So we can enjoy great health taking proactive steps. Cavadex would be an extreme proactive step to decrease our burden of vascular disease. People would do better. We would save billions of dollars. Billions of dollars.
And so, just for clarity, nothing being absolute, but perhaps this is, if it were your friend, your brother, you, my mom, my dad, and someone said, listen, I've had a bypass and they tell me I'm in trouble again. My arteries are closing, my cholesterol's high, I don't seem to have a path to take, you would, period, say Cavadex.
Absolutely, why not? You'll meet one of my friends this afternoon.
Okay.
And he will tell you his story. So I will tell my friends, I will tell everybody, if you are suffering from symptoms of arterial disease, why not take Cavadex? Do everything else, but why not take Cavadex?
Makes it pretty clear.
Yes.
Well, so it's one thing when people tell you they're feeling better and you see them doing better, but it's another thing when calcium scores are involved and you have data to suggest that they ought to be feeling better. What's the calcium score data look like?
Well, this is early days. We've been using this only 2.5 years, and only 2 of my patients have had calcium scores before and after, and they fell dramatically. And that's not supposed to happen. In fact, that just doesn't happen. If you can slow down the rate of progression, you think that's great. No one shows that you can reverse it. Now, that's just 2 patients. Kyle, who gathers data from people around the world, says, oh, this can happen all the time. We're seeing it. Thus, we're going to take 50 of our patients and do a pilot study. We're going to obtain a calcium score. They're going to take Cavadex for 6 months. We're going to repeat it. So we'll have data on 50 individuals. And that will be,
great.
Now that is not a randomized double-blind study. This is a low-budget in-house study, but it will prove the point, and it will guide us when we construct future studies. So in 6 months, I should have what I guess you might call proof. Now, a purist could say, well, how do you know it wasn't the other things you're doing, except all the medicine in the world right now, no one has reversed the coronary calcium score. So if we add in Cavadex, it gets better, it's the Cavadex.
And I think your opinion is that there's some wrong-minded thinking regarding cholesterol-reducing medicines and calcium
Yes.
scores. What is that about?
Okay, so the calcium score reflects the extent and chronicity of your atherosclerosis and your vitamin K2 status. We get K2 from meat and dairy. K2's job is to keep calcium out of the arteries. People who take in more K2 than others early in life have less calcific atherosclerosis later in life. And we get K2 from meat and dairy if the animals eat grass, as they do in France.
Okay.
We buy animal products in the grocery store, they're fed corn and soybean. Our American diet is deficient in K2. K2 might be part of the French paradox. So K2 deficiency plays a role in the calcium score. In addition, if you have vascular wall calcification, your body makes a protein called matrix GLA protein. If it is activated by K2, it pulls calcium out. If not, it promotes calcification progression. Calcification begets more calcification by increasing your need for K2. So when we're thinking about the calcium scores, one of the phenomena that plays a role is K2. So if you have a high calcium score and you're my patient, I'm going to give you K2. The rest is the atherosclerosis. Now, people are getting these calcium scores and they're being terrified. They're being talked into a heart cath. Oh, you have a high calcium, oh, and it's in the widowmaker. So now you are terrified, your wife is terrified, you're undergoing a heart catheterization you don't really need. Or you don't want to do a heart cath, you have to take a statin. That's the standard of care. So we put you on a statin. What is the effect of statin therapy on the coronary calcium score? It actually increases it. Because statins deplete coenzyme Q, vitamin K2, and testosterone in men. Because they're metabolic poisons. Now they're helpful, but we do good things, we do bad things. So statins actually accelerate vascular calcification by depleting K2. So in a sense, I mean, there's benefits of the statin, but it's really not going to help you with your coronary calcium score. Whereas we're pretty sure Cavadex is going to make that problem go away.
Amazing.
Yes.
Thanks, Jim.
My pleasure. Thank you.